So this is the second session of the Introduction to Major Trauma at Queen's Medical Center. Remember that Queen's Medical Center is the East Midlands Major Trauma Center. I do encourage you to listen to the first part of this major trauma recording. Is in two parts, like we said. Also, to make reference to some of the resources on the CP3 Moodle page to learn more about major trauma. This second part covers the learning activity that would give you an opportunity to practice some of the points that has been described and learned in the first session. The aim of this second session is to go through an activity, 3 cases that would help practice writing an SBAR. And in the activity as well, you will be required to describe the trauma code, which will essentially help you practice, like I said, some of the things that we described in the first session. So if you've not listened to the first session, this would be a good time to pause this video and go and listen to part 1, and then you can join us again in part 2.
So for the activity, you will need an SBAR sheet and copies of some of the pages of the trauma booklet. It would be ideal if you have these to hand before playing the session. So here we have an example of the SBAR sheet that we use in the emergency department.
It would be useful to go through the AT mixed again. The SBAR is usually presented in this format. Remember, we said in part 1 that when the EMAS crew call the emergency department, they usually would present in this AT mixed format: the age, the time, mechanism, injuries, and signs, and the treatment that is given. When you start reading through the cases as we present them, please do try and divide it into this sort of format. The format for each case will be something like this: what trauma code and why, complete the primary survey findings and discuss what injuries you're concerned about and why, and make an SBAR referral to the emergency department registrar or senior based on your assessment and your recommendation.
So here we have the front sheet of our trauma booklet. It would be useful if you have these as a reference for each trauma code.
As a warning, the next slide will be fairly busy because this is a point where we present the cases to you. With your pen and paper, are you ready?
So case number 1. Joe Smith is a 21-year-old who is normally fit and well. He has recently taken up cycling to lose weight. He's been out today on his bike wearing t-shirt and shorts. Because of not wanting to mess up his hair, he left his helmet at home. He's been hit by an Audi TT at about 30 miles an hour, side on. He's been thrown against the window, cracking it before rolling off the bonnet. The Audi driver stayed with Joe and called 999. He thinks Joe vomited a bit. Joe has a laceration to the right of his head. His blood pressure is 130/81 and his heart rate is 120. Temperature 36.5. His chest is clear on auscultation. He denies any chest, abdominal or pelvic pain on palpation. He doesn't remember the accident, and otherwise he is answering appropriately.
At this point, we would give about 45 seconds for you to make some notes. If you do require more time, I would encourage that you pause this video and take as long as you want to formulate your summary of this case. Right, the task you have is, like I said before, so questions are: what trauma code is Joe and why? And complete the primary survey findings and discuss what injuries you're concerned about and why. You will then be required to make an SBAR referral to the emergency department registrar based on your assessment and recommendations. one way to think about this is if you had a colleague with you, you can discuss this amongst yourself. You may also want to make a note of this. So you may say it aloud as you would say. Think of yourself going through a primary survey as we discussed in the first part one of this session. Think around what things you'd be worried about, what things you'd be concerned about, and make a note of those. So if you said code green, that is just about correct, based on where the case that you've reviewed. We're going to review this together. The arrow there points to where you are expected to see this case. We're in the real trauma situation. That's where we'll be placing this patient on. So going through this case, then, what are the risk factors that has made us call a code green trauma call for our patient, Joe Smith?
So the concerning features for this case. So firstly, it's important to note that Joe is normally fit and well. He wasn't wearing his helmet and he's been hit by a car at approximately 30 miles an hour. Where we would be concerned is that he has bullseyed the window. There's been vomiting on scene with a visual head injury. He's tachycardic with a normal blood pressure and has amnesia regarding the events.
So it doesn't remember the event. So we're thinking of a significant head injury here, isn't it? So if I would write a primary survey for Joe Smith, I would go through things like airway, normal, chest examination findings is clear and auscultation. There's no tenderness that we've seen. And then from the C, the only concerning thing there is the heart rate of 120, isn't it? Are you concerned about this?
So I would be concerned about the heart rate. However, as a number on its own is difficult to interpret, this shows the importance of a secondary survey whereby we can observe Joe and see if this heart rate is physiological or due to anxiety or pain.
I suppose mention of the word physiological is quite about right, because most of our patients will usually be worried and they may also be in pain, which can raise the heart rate. Secondary survey is usually quite important to pick up things that's been described in most of our trauma session. The so-called blood on the floor and 4 more. And the 4 areas we're thinking about here are?
So the first one, like Stephen said, was blood on the floor. The 4 more would be head, chest, abdomen and pelvis, and long bones.
So the head in this case we're worried about, and the other 4 like you've described. So on the D, we have said that we think that this patient has had a head injury, and so we are going to scan this patient, are we?
Yes, I would say that based on the examination findings, a CT head would be sufficient for Joe.
Okay, I do agree, because we can watch that heart rate, and if it settles, if it doesn't settle, we'll think about other things that would do. If, for instance, a venous blood gas would be very useful to check the lactate in that situation. And if indeed we're still concerned, then we can proceed to scan the rest of Joe. Next thing to think about is how then would you make an SBAR referral to a senior who wasn't present at this trauma? You may write this down or just discuss this with your colleague. So, moving on to case 2.
So, case number 2, Joe Smith is a 59-year-old company director who has been out drinking at a work do. She is normally fit and well, although was recently diagnosed with the DVT and started treatment. On getting home, her partner heard her thud down the stairs. Joe was found at the bottom of the stairs unconscious. It looks like her chest went through a wooden coffee table, smashing the table in 2. When the ambulance crew got to Joe, she was lying on her back at the bottom of the stairs with a pool of blood coming from the back of her head. She is opening her eyes to voice, localising to pain, and is confused. She has bruising under her left bust and to both flanks. Her heart rate is 135 and her blood pressure is 100/79.
So as usual, we're going to allow time for you to make some notes. Again, if you require more time, please do pause the video at this point and take your time, make some notes. Okay, the task here is what trauma code is Joe and why? Complete the primary survey findings and discuss what injuries you are concerned about and why. And make an expert referral to the emergency department registrar or any senior based on your assessment and recommendation. I think you realize in this case that Joe will need a code AMBER trauma call and will dial 2222 and request for a code AMBER trauma call based on those two findings. Well, three findings in this case: GCS less than 14, heart rate greater than 130, and chest injury with altered physiology. We'll together look at some of the concerning features.
So from this case, the pertinent points would be that Joe has been drinking, so there is obviously alcohol on board. She is anticoagulated for a recent DVT. She has fallen down a full flight of stairs and is unconscious with visible chest and head injuries and obvious loss of blood. She has a reduced GCS with eyes opening to voice, localising to pain and confusion. She has visible bruising to her left bust and to both flanks, and she's also tachycardic.
So this finding seems to cover all areas of the body, basically the head, the chest, the abdomen, and the fact that Joe Smith, a 59-year-old female, is quite unstable with a heart rate of 135. Most of these findings you would have had pre-hospitally, referring to the fact that the crew may have mentioned some of these findings before the patient arrives. And so you would want to think about how you would set up your team as a team leader. You would need most of these clinicians described in this red trauma formation. Although this case is an amber trauma call, you would at least need the anesthetics in this case, the nurse, the CSW, and a primary survey doctor. In this case then, thinking around what we discussed about where patients will likely go: theatre, scan, or just stay in the emergency room?
So I think this patient would certainly need a trauma CT in the first instance.
So main will scan the head, the chest, the pelvis, and that gives us and the abdomen as well. That would also give us the imaging of the spine. So CT trauma there is CT head to pelvis. So moving on to the final case.
So case number 3. Joey Smith is 18 years old. He has a history of ADHD and substance abuse. He has been out tonight drinking with friends. He has consumed a large amount of alcohol and taken cocaine. During an argument over a girl, Joey was stabbed to his chest. He was seen to collapse and stop talking. One of his friends thought they heard bubbling coming from his chest. He is pale and sweating. With the crew, his heart rate was 145 and blood pressure 85/60. He is making noises, opening eyes to pain and localising to pain. On arrival to A&E, his blood pressure is 79/56 and his heart rate is 149. Lactate on his VBG is 4. There is a sucking wound in his chest. He has air entry throughout his lungs, and he has a small visible stab wound to the left lateral sternal edge with quiet heart sounds.
This chap is pretty sick. I will let you make some notes at this time. Again, if you require more time, this is a good time to pause and take as long as you want in sort of formulating your clinical reasoning as to how you would approach this case. You should all know the drill by now. Hope you've been able to look through this task, and you can, as per previous case, go through this yourself or with a colleague of yours. So, what do you think then? This case is a code red, of course, because of how sick that we've described this Joey Smith as. He's a young chap who we've sort of gone through the case about, and this is a good time to introduce the concept of the shock index, which is described on this trauma booklet. A shock index of greater than 0.90 pre-hospitally will make this automatically a code red. So, what is the shock index then?
So the shock index is calculated by dividing the heart rate by the systolic blood pressure.
And what does this tell us?
So the shock index indicates the level of occult shock, especially in trauma or acute hemorrhage.
So we bring Joey Smith in, we'll get our team together. He's a code red, and we expect to get very senior colleague attending this code red. So we need to think around the significant findings in the history or the presentation of Joey Smith that has made us call this as a trauma code red.
So again, the concerning details here would be that Joey has alcohol and cocaine on board with a history of substance abuse. He has been stabbed as witnessed by his friends. He has then collapsed and seen to stop talking with audible bubbling coming from his chest. His observations with the crew is that he's tachycardic and hypotensive. He is grunting, opening his eyes to pain and localizing to pain. And he still remains tachycardic and hypotensive on arrival to the emergency department with a lactate of 4.
Nice, quite significant. And in this case, again, this is one of those where pre-hospitally and before the patient arrives, a very good pre-brief will be useful in this case to think around how you would, again, organize your team. We talked about different consultants that would usually be part of this trauma code for this young guy. One quick one to mention is this group. They will be very useful in this case of trauma in a young chap. So think around and ask around for the red thread team as you find yourself in one of these scenarios. A very quick introduction to the severe trauma, which makes up 20% of all our traumas. The severe trauma is usually less obvious and involves falls less than 2 meters with all the co-founding factors associated with illness in the elderly. This group of patients are less likely to be trauma called, so people would go, oh, it's a very low risk fall, but we have to think about the co-founding comorbidities and the iatrogenicity that could happen in this group of patients. They may have injuries similar to the younger person in major trauma from a seemingly innocuous mechanism. For example, falling out of a chair. These patients are most likely going to be discharged or admitted to medicine with these injuries, and invariably they would have very poor outcomes. We've seen this happen a few times. So we have to have a high index of suspicion and a low threshold to escalate these patients. And we should not be falsely reassured by their observations. We ought to be on our guard to pick up signs of injuries and remember our primary survey principles at all times, regardless of whether we are in a trauma team or not. So more than likely these patients will be seen on their own by one clinician. Please do follow the primary survey principles in this case. We have come to the end of these sessions. If you do have any questions, please feel free to add. And when you come to your rotation, please do ask us questions regarding this or what we discussed in the first part of this session.
So I hope you've been able to see that there is a team approach to trauma, and we have to be very thorough and systematic in how we manage these patients. We hope that during your attachment you are really able to watch the team in action and hopefully have some experience of being in the team yourself.
Welcome to the team. Thank you.
Thank you.